Well, Professor Skownicki and Archer, thank you very much for inviting me here in Krakow. I'm sorry I don't have a Polish father.
Nobody's perfect.
And I even have to admit, when I left Belgium 2 days ago, and although Polish people are very kind and friendly, I still had the idea that Polish cities would be grey, made out of concrete and boring. But after 1 hour walking here in Krakow, I was really impressed, and I think we can.
It's vice versa. Very kind of you to say so.
And I think we can compare Krakow to, for instance, Barcelona or Madrid. So it's a really very nice city. I'm here also to talk about science, and these seminars are called Complex Treatment of Plasma Cell Dyscrasias, and this is also the case for relapsed multiple myeloma. So this slide was already shown by Professor Ludwig. It is very important to remind that multiple myeloma is a disease that relapses, and the treatment that we give in the beginning or at the first relapse will influence the treatment that we will be able to give later on. And this is certainly true with the new drugs that are currently being approved. For the workup that is done at relapse is quite similar to the workup at diagnosis. I think we can do a bone marrow biopsy or cytology in cases of non-secretory myeloma, or when there are signs of myelodysplasia. Cytogenetics are really important when they were not available at diagnosis or even normal, or when there's an aggressive relapse to exclude that there's a clone with deletion 17p, for instance. The definition of relapse is that there's an increase of 25% from the baseline in the M component, or an absolute increase of more than 0.5 gram per deciliter. Or the development of new plasmacytomas or bone lesions, or an increase of more than 50% in the size of bone lesions. Hypercalcemia, anemia, or renal failure that can be seen. When we see a patient with myeloma and we think of a new treatment, we should ask ourselves some questions. Do this patient really need a treatment? Are there some new high-risk features? What drugs have been used? What was the response to these drugs? How well is our patient? And how well is his marrow still functioning? And what are the patient's preferences? Because for some patients, we can indeed watch and wait. And some patients show very slow increases of their M component, and they can be stable or slowly increasing during months or even years. However, if there's a sudden important relapse, or at diagnosis there was already an aggressive presentation, when there's a large increase in M protein, and this is certainly true for the light chains, apparition of anemia, or sometimes unexplained complaints of the patients, then we should consider immediate treatment. Now, the treatment that we choose depends on 3 different factors. Some are patient-related, some are disease-related, and others are treatment-related. And for the patients, we have to look to their age and their frailty score, their comorbidities, their transplant eligibility, the side effects of prior therapies, and for instance, neuropathy or thrombosis. In disease-related, we have the type and the risk status of the disease, the response duration. If there is a refractory disease presence or extramedullary disease, this will influence our treatment and the aggressiveness. And in the last update of the IMWG guidelines, this high risk at relapse was defined This was based on previous retrospective studies when there are adverse cytogenic abnormalities already present at diagnosis, or when at relapse there is extramedullary disease, a short remission duration after the first treatment, high ISS stage at relapse. Something really important is isotype transformation, when you, for instance, secretion of light chains, when before you had heavy chains, or hyposecretory disease, or high LDA levels. When there are such a high LDH levels, I think it's necessary to verify the presence of extramedullary disease or signs of plasma cell leukemia. So these different criteria define a high-risk disease at relapse, and these patients will be treated in another way. And there are also some treatment-related factors. I think of which one bone marrow reserve is a very important one, use of prior autologous transplantation. And all these guide us. These three different factors will decide on the treatment. For instance, in the age we have to reconsider stem cell transplantation. Patients with a good prognosis, we can eventually retreat with the same regimen. For high-risk cytogenetics, the use of proteasome inhibitors was already mentioned before. And for patients who show, for instance, an insufficient response, we should switch drugs. And if all regimens are exploited, we can use, for instance, DCEP or DTPase regimens. The four questions that we need to ask is, can we retreat our patients with agents that we used before? When should we switch? What about comorbidities? And when should we use single agents or drug combinations? So at first relapse, I think we need to switch if there's a short remission, or treatment before was very long, or when there were very much toxicities. We can retreat if there's a long remission after the first treatment. If the short upfront treatment was only very short, for instance, a VTD or VCD induction treatment, followed by autologous transplantation, and this patient is stable or is in remission for more than 3-4 years, we can use VTD at relapse, and when there was no toxicity. We need to think how to optimize our treatment, whether to use 2 or 3 products. And retreatment with Imids is, for instance, is feasible, and this was shown in a study by the Mayo Clinic, published in 2009. And here, patients that received before lenalidomide were retreated with lenalidomide, and there were up to 50 to 60% of patients that responded. I think retreatment with thalidomide is less promising because there was only 30% of patients that responded here. And this was also seen in the different studies with Revlimid. In general, when Revlimid was re-given, response rates were about 60%. Now, sometimes we can also add a drug to an existing combination, and this was done in the Netherlands, where they added cyclophosphamide to Revlimid for patients that were refractory to Revdex. This was published in 2010, and they're performing now a phase 1/2 trial where they added, and they went looking for the exact dose of the different drugs. So these are the different combinations that they tested, and they finally found that when you give 25 milligrams of Revlimid with 50 milligrams of cyclophosphamide and 20 milligrams of prednisone, you achieve very good results with this regimen, with responses that go up to 60 to 70%, and also in patients that were len and bortezomib refractory. So adding a drug can be an option for some patients, and this enables you also to maximize your treatment that you're giving. For bortezomib, the same is true, but we see that responses are not that much. The responses are about 57%, and these responses do not prolong very much, only to 5 to 8 months, no, 5.8 months, which is shorter than Revlimid. And there are different institutes that propose guidelines on retreatment, and in general they say that if you remain in remission up to 9 months, that you can consider a retreatment. Very important is also to consider a second autologous transplantation, and these are results from the Mayo Clinic that show that the overall response rate was about 80%, with a treatment rate mortality of 4%. But the time of progression after the second transplantation depended on the time of relapse. Patients that progressed very soon had a very short progression-free survival. And this was confirmed in a German study from the group of Heidelberg. They had about the same response rate, of 80%, with a treatment-related mortality of 3%. And they, by univariate and multivariate analysis, could identify the ISS score at relapse and the time after the first transplantation as 2 major criteria. Here you can see that patients that progress within or earlier than 18 months have a worse survival afterwards. And this is when we combine both the ESS score and the duration of response after the first transplantation, where you can see that patients who have a very low risk are the patients who are ESS1, who have more than 18 months of remission after their first transplantation. I think that this 18 months can be considered as a cutoff to decide whether to review autologous transplantation. Now in 2015, 2016, there are different new molecules on the market. There's carfilzomib, elotuzumab, ixazomib, and Daratumumab. So there are monoclonal antibodies that have anti-tumor effects through activation of NK cells, macrophages, and also some direct anti-tumor effects. And different antigens have been exploited, and we mostly know CS1 and CD38, but there are also studies now ongoing with specific antibodies against BCMA. And there are also the checkpoint inhibitors that have some anti-myeloma activity, at least in combination with Revlimid, for instance. Daratumumab has some direct anti-tumor effect, but it was also shown that these anti-CD38 treatments could have an effect on regulatory T cells and immune modulation. Daratumumab targets, as you know, CD38. It has a very good anti-tumor activity as single agent, with up to responses to 30 to 35%. There's a benefit in PFS and overall survival that was shown, and also in high-risk patients. There is no severe toxicity, and it is currently proven to be effective in relapse setting, but in the future in the future, and now there are studies ongoing in frontline and in maintenance. And Johnson & Johnson is also working on a subcutaneous administration mode for this antibody. Another one is Elotuzumab. Elotuzumab is directed against CS1, that is expressed by many tumor cells. But Elotuzumab can also activate NK cells by linking the Fc part of the antibody to the CD19 antigen on NK cells, which directly activates NK cells. And on the other hand, it also binds to myeloma cells. This CS1 or SLAM-F7 is also highly expressed in myeloma cells. At this moment, there is only a PFS survival that has been proven. It seems to be effective also in high-risk patients. It has also no severe toxicity, and frailer patients can also benefit from this patient. And again, at this moment, publications only showed the use in a relapse setting. There are different proteasome inhibitors. I won't talk to you about the mechanism of action. I think that you know it. We all know bortezomib, which is a reversible binding of the proteasome. Carfilzomib is a second generation that irreversibly binds to the proteasome. Ixazomib is an oral form, and the final or fourth form is proteasome inhibitor is marizomib. Now, these different molecules have been published in 2015, 2016. And it was the ASPIRE trial that looked to KRD versus RD, the ELOQUENT-2 trial to Elotuzumab Revdex to Revdex, Tourmaline evaluated ixazomib Revdex to Revdex, and recently was publication of the CASTOR trial on Daratumumab Velcade-Dexamethasone versus VD. Now, it's very difficult to compare these different trials. As you can see here, the inclusion of high-risk cytogenic patients is different among the different studies, and also the definition of this high-risk disease was different. In the ASPIRE trial, for instance, you needed 60%, at least 60% of the cells, of the tumor cells, had to harbor a deletion 70p to be defined as a high-risk cytogenetic. While in the ELOQUENT study, already more than 0% was sufficient to be included in the high risk. Also, the number of prior lines was different. As you can see here, there are more people with advanced disease, with more lines in the ASPIRE trial, as for instance in the Tourmaline study. Now, these agents all had very good results with response rates that go up to 85%, and PFS for KRD that goes up to 26 months. From the ASPIRE trial, there's a sub-analysis published that showed that also for high-risk patients, the PFS was quite long, which goes up to 23 months, with also good responses that are not that different compared to the overall population. Now, these three regimens, KRD, Elotuzumab, and IRD, were both very effective in patients with high-risk cytogenetics, and also patients that received at least 3 or 4 lines. And these are the graphs of different studies. I also added here the Daratumumab Revdex study. That is the Pollux trial that was shown at the last EA meeting, where you can see that the response rate was up to 80%. And these are the results on progression-free survival. Here the RD results are, this is the mean of the different 4 studies that included Revdex as a comparison, and Veldex also as a comparison. And in the DARA RD trial, this progression-free survival has not been reached, for instance, which is very important. Now, all these treatments have their price. And here you can see what the price in US dollars is for the different treatment regimens. And to make able to compare them, these authors calculated the price to obtain with each regimen a gain in progression-free survival of 12 months. And you can see that Velcade is about 80 or 90,000 US dollars. Pomdex is also very expensive because it's about 150,000 US dollars, but it has not much costs in administration. And the most expensive one is KRD, which goes up to $250,000. Now, we speak a lot about cost effectiveness in health economics. And in the ASPIRE trial, it was compared what the total costs were in the different arms. You can see here that the RD has a total cost of $300,000. And this resulted in a QALY of 4.21. I don't know if you know what the QALY is, but the QALY tries to estimate your quality of life. For instance, a blind man that still has to live 10 years and who scores his life quality as 50%, he has a QALY of 5. So RD results in a QALY of 4.21. And the cost-effectiveness ratio of this RD is $772,000. KRD is much more expensive. It costs in total $483,000, but gives a better QALY, 5.8 years, which makes $82,000. Now, this it is not the cost-effectiveness ratio which is important. It is the incremental cost-effectiveness ratio which is important, and which is also termed the ICER. So you see here the initial price of Revlimid, which is $300,000, and we see that KRD costs $180,000 more, but results in a gain of 1.6, which makes that KRD compared to RD has an ICER or an incremental cost-effectiveness ratio of 107,000 per QALY. Now, there are different combinations possible, are how patients respond and what their costs are. And this is, according to the authors, all the different possibilities that can be seen during treatment with their price. And here the authors put a cutoff of $150,000 threshold, and they say that here 60% of the situations the price was below 150,000. Now we have to know that, for instance, in the UK there is the National Institute of Health, which use the NICE criteria, and they put a cutoff at $50,000 per QALY. So all these treatments are much more expensive. Now this cost effectiveness is also a double-edged sword, because the firms know that a land has a certain budget, and they know that they have to find a price which is somewhere between this 50,000 and this 150,000. So instead of proposing the price of their product, they will calculate, or they will ask the country, what are you willing to pay for this drug? Which makes that prices go very high. I still hope that your vice minister was still here, but now we were thinking in Belgium. We were lastly thinking about how would these different schedules fit in our treatment approaches, and we decided to make a difference between standard risk patients and high risk patients. From an ethical point of view, I'm not sure whether this is correct. I'm not sure that we should treat low-risk patients otherwise than high-risk patients, because they also benefit from these treatments. But for instance, if we take an elderly patient that has been treated with VMP before, that is in relapse, we would first like to see whether this relapse was indolent or aggressive. In case of indolent relapse, we can consider to give RD, and if RD is not possible, to give carfilzomib dexamethasone. If it's more aggressive disease at relapse, we should try to give him the best available treatments. And at this moment, these treatments are carfilzomib Revdex or Daratumumab Revdex. For frail patients, we can keep the Revdex, because it allows you only need a visit once a month to the hospital. But on the other hand, for ERD and also for ixazomib, you have to need to do more frequent controls and some increased toxicity. For patients that received Lendex at front line and that progress, if this progression was really early, I think that we all agree that we need to switch classes and go to proteasome inhibitors. We can choose between VCD or carfilzomib dexamethasone, or a proteasome inhibitor combined with Daratumumab. If it's a late relapse and the disease was sensitive to lenalidomide, we can choose to add carfilzomib or Daratumumab. And for resistant disease relapses, we should again change classes. In third line, it is mainly POM, to which we can add cyclophosphamide, or again to take Daratumumab or carfilzomib-based regimens. For high-risk, standard-risk patients and transplant-eligible, so the patients receive VTD or VCD, or in the US, VRD, at relapse, I think it's important to reconsider a second autologous transplantation, certainly if this progression was later than 18 months. Before 18 months, which is, of course, very bad for the patient and indicates a very aggressive disease, treatment should be maximal at that moment and should consist, according to me, to carfilzomib or Daratumumab combined with Revdex. And for fit patients, try to combine lenalidomide with Elotuzumab or ixazomib. In patients with high-risk disease, it's the same. So here, the disease itself is already more aggressive. So we need to think of a potent therapy at relapse, and there the fitness is important. For patients that are able to come a lot to the hospital, we can consider carfilzomib, Revdex, or Daratumumab. And when they are less active, consider ERD or IRD. And again, for patients that received Lendex, early relapse, we change classes. And for late, we look to lenalidomide sensitive or resistant disease. High-risk disease that relapse after an autologous transplantation, we still can consider, if this is later than 18 months, to consider a second autologous transplantation. But we should first reinduce these patients. And again, very fit patients, I think we should go for the maximal therapy available at that moment, which we can lower down in fit patients. So these are the kind of patients evolution and the treatment that we can think of. The last slide that I would like to show is some advice that I received by email from the Cancer Network, which is a cancer association that sends out email, and they give this advice to avoid saying 7 different things to your patients. And the last one was try to avoid to say patients not to travel. And this is for patients very cumbersome because these patients or our patients still want to continue their life. And traveling still is very important also for them. And this is a patient that I follow who is 60 years old. He has a tetraparesis because of a severe arthrosis at the cervical spine. He has an amyloidosis of his heart with only 10% of heart function left, and also macroglossia, to which he hardly can eat. But this patient was able to travel to the south of France 1 month ago, and when he came back, he was really relieved, and I think that he felt, in his quality at least, or in his quality of life, he was 80% better. So I prescribe him now to travel once every 2 months to go to different vacations. Thank you.